ahead and enter your questions in the Q&A at the bottom of the screen. We'll keep compiling all of those questions, and then Dr. Arnold will answer the questions at the end of the session. So be sure to continue to submit those throughout the presentation. So here to share on the topic of newborn screening and FAOD is Dr. Georgianne Arnold. Dr. Arnold graduated from Indiana University with degrees in biology and chemistry. She has a master's degree in medical genetics from Indiana University, Purdue University at Indianapolis, and graduated from medical school at Upstate Medical Center in New York. She completed a residency in pediatrics at Northwestern University and a fellowship in genetics at the University of Colorado. She's board certified in pediatrics, clinical genetics, and clinical biochemical genetics. Previously, Dr. Arnold was faculty at the University of Arkansas and the University of Rochester. She is now professor of pediatrics and clinical research director at the University of Pittsburgh Medical Center. Her main interest is clinical research in inborn errors of metabolism. She is currently conducting numerous clinical trials for a variety of metabolic disorders and is the longitudinal project principal investigator for the National Rare Disease Consortium for phenylketonuria. Did I say that right? Dr. Arnold has authored more than 70 medical publications and received the Shapiro Award for the best publication by a Society for Inherited Metabolic Disorders in the journal Molecular Genetics and Metabolism for her paper, A Delphi Clinical Practice Protocol for the Management of Very Long-Chain Acyl-CoA Dehydrogenase Deficiency. You're challenging me today. She has presented papers at numerous national and international meetings and is currently the president of the Society of Inherited Metabolic Disorders. Please join me in welcoming Dr. Arnold.
Well, thank you. Thank you for the lovely introduction. So yes, I'm here today to talk about something near and dear to my heart, which is newborn screening. Now, when we start talking about biochemistry, people, think it's difficult. But what I hope I can show you today is that it's not as hard as you think. And you'll feel much more confident about newborn screening and what it means and how to interpret things when we're done. So I want to talk about the history of newborn screening because if you want to understand where you're going, it's usually very helpful to understand where you've been. And then the new technology that made fatty acid oxidation disorders possible to have newborn screening, the really important role of parent advocacy, what happens when the federal government gets involved, fatty acid oxidation defects in particular, and then pitfalls and future for newborn screening. So newborn screening is really at the nexus of medicine and politics. And this theme is going to come up over and over again in the next hour. I heard on TV the other day, when you mix science and politics, you get politics. And sometimes for newborn screening, that's been true, but fortunately, it hasn't always been true. So we tend to think of newborn screening as something we do for metabolic diseases, but in fact, the most common diseases, you have to actually get to like number 5 on the list before you get to a metabolic disease. Hearing loss, hypothyroidism, all of these things are actually more common. So newborn screen started with a mother who had 2 children with intellectual disability and who went far and wide, knocking on every door she could find until she could find somebody to tell her what was wrong with her children. And in the process, she discovered Dr. Furling. This was Denmark. And he asked for a sample of their urine. Now, the urban legend is that she brought him 8 gallons of urine. I don't know if she exactly brought 8, but she did bring a lot, and he was able through that to find the phenylketones in the urine and worked out the defect in phenylalanine metabolism. And it was named Furling's disease. It was named for him and not the mother. Or now we know it mostly as PKU. And that was sort of the original disorder that led to the development of newborn screening. And a couple decades later, in the 50s and getting into the 60s, they discovered that you could prevent the intellectual disability by not feeding children phenylalanine, which is the amino acid they can't metabolize. And they began to realize that if you didn't diagnose them until they already had brain damage, then you really couldn't help them so much. So you really needed a way to identify the children beforehand. So that continued with a dad. Robert Guthrie is considered to be the father of newborn screening. He had a son with intellectual disability, though it wasn't PKU. And I heard he had a niece with PKU. I haven't seen that verified. But he developed what's known as the Guthrie test. So he found a bacteria that required phenylalanine to grow. And he saturated this plate with the bacteria. And then in each of the little wells was spotted some blood from the newborn screen of a baby. And in the middle, you can see that there are controls. So there are spots of exactly how much Phe is in. And you can see that there is a positive on the plate. And you can sort of estimate about how much Phe is in it by comparing it to the controls. So this was an easy, cheap, fast way to screen for PKU. It took off kind of slowly. So he developed this plate, the Guthrie test, or the bacterial inhibition assay, in '58, and tried to push to get babies screened. And it didn't really catch on so quickly. But by 1961, people were getting the message. And here's a nice picture of poor baby having their heel pricked, and there's a positive on the bottom row of that Guthrie plate. But I don't know how many people remember President Kennedy had a sister with developmental disabilities, and he was very interested in preventing developmental disabilities. And they funded a lot of Kennedy centers. And in fact, I was trained in a Kennedy Center for Developmental Disabilities. And he really got behind this, and they made a voluntary field trial of 400,000 children to see what would happen if you tested them when they were born. And it seemed to be successful. And Dr. Guthrie and others really wanted to push for mandatory screening for every baby. But, you know, in medicine, we like to practice evidence-based medicine. We like to know what we're doing and why. And there hadn't even been any publications on that. Dr. Guthrie's article didn't come out till 1963. So they were saying, you want to do this to these babies without even any scientific evidence behind it? People were concerned that maybe the test wouldn't work, that maybe the treatment wouldn't work, that maybe it wasn't even realistic to treat children for years and years with this very restricted diet. And one of the things to remember is there's nothing new under the sun. If you think of all of the arguments that came out in the past decade over having a single payer medical care system, socialized medicine, government control, those were the same arguments that were being made after World War II, when most of the world was going to a single payer medical care system. And they were the same arguments that were made about newborn screening. That yes, every baby should be screened, but it should be voluntary. You should do it at your pediatrician's office when you go for your 2-week visit. And, you know, it really, you can't mandate it. And so the American Academy of Pediatrics and the American Medical Association actually didn't support mandatory screening at that time. But then things kind of took off. So Massachusetts, if you remember, that's the state that President Kennedy was from, did a 6-month trial of screening every baby in Massachusetts. And they found 7 babies with PKU. This was really beyond what they expected. And this led Massachusetts to pass a law for mandatory newborn screening for PKU. Interestingly, over the objections of the Massachusetts Medical Society. Once that program took off, people began to realize you could do this for other disorders. So with the Guthrie plate, if you had a bacteria that required Phe to grow, well, could you develop a bacteria requiring leucine to grow? So you could do maple syrup urine disease. And then other disorders, they developed other simple technologies, hypothyroidism. But eventually, by the late 60s, they began to realize that they needed some guidance. This thing was taken off and nobody was driving the train. So by the late 90s, most states were screening for at least 7 disorders, but it was still somewhat limited. But in the late 60s, when things were starting to take off, people began to realize they needed some rules. So in 1968, the World Health Organization published the Wilson and Junger criteria that basically said, what kind of diseases should we be screening for? Well, there should be a simple way to get it, the sample, you know, a nice heel prick. There should be public benefit and acceptance. There should be a suitable and simple test method. The cost should be acceptable. It should be treatable, should be detectable in the newborn period, and it should be of benefit to the patient to treat them pre-symptomatically. And there needed to be available resources to treat the patients. So why didn't FAOD go on newborn screens? Well, it wasn't there yet. In fact, MCAD wasn't even described until, oh gosh, the early 80s. So you did not see fatty acid oxidation in early newborn screening. But then there was a new technology called tandem mass spectrometry that enables the identification of a lot of molecules at a very small sample size. And suddenly you could go from 7 to 50 disorders. So let's talk about the new technology. Tandem mass spectrometry, or TMS, the process is molecules are ionized, pass through a magnetic field to a detector, and the mass and the charge on the molecule affect its deflection. And then when a molecule with the desired mass to charge ratio is detected, it's reionized or broken up again and it goes to the second mass spec that then further identifies it. So in picture form, it goes through you take your sample, your blood that has all kinds of things in it, and you put it through the first mass spec and say, pick out the class of things you want. You refragment it, it goes to the second mass spec, and it will actually detect and quantitate how much of the things you were actually looking for are there. So this is from Dr. Dieter Matern at Mayo, and he wanted to answer the question, how many doctors at Mayo drive a Mercedes? So think of the first mass spec as looking for cars. So you take whatever, feed it into the mass spec and say, find me cars. Then when you find the cars, you send them out onto the Autobahn in fog and make a big collision. And then you sift through the remains for common fragments. In this case, a Mercedes hood ornament. So this is basically the principle of tandem mass spec. You take a blood sample, you pass it through, say, give me things that might be fatty acid oxidation intermediates. You send it through the cell again, and then you can identify them. And he actually went out and counted. There were 3 cars that were Mercedes in the parking lot. So how do you apply this to fatty acids? Well, most of you have probably heard of carnitine. Carnitine is a molecule your body makes it, you consume it in food, and its main job is to mate or esterify with long-chain fatty acids to bring them into the mitochondria so you can burn them for energy or oxidize them. So short and medium chain fats don't need carnitine. They can pass right into the mitochondria and get metabolized. But long chain fat can't get in there by itself. But carnitine is a fickle lover. Carnitine will esterify anything that has a lot of carbon atoms on it. And if you remember, fat is hydrocarbon. It's carbon and hydrogens, kind of like gasoline, kind of like what you burn in your car. So it will esterify not just long chain fat, but any carbon-based intermediate, or perhaps a partial breakdown product of fatty acids. So you'll take the blood spot, you remove some of the blood, put it in the solution, ionize it, pass it through the mass spec, and you find what the detector found for molecules containing carnitine. Then you reionize it, break it up into characteristic size fragments, and the second detector detects the signatures of what was esterified to your carnitine. So it's a way to take blood that has thousands of things in it and break it down to find just a couple things. So in the 1990s, Charlie Rowe and Dave Millington began to apply tandem mass spec, or MSMS, to patients with inborn errors of metabolism, or IEMs. And then in 1996, Ed Naylor started using this for newborn screening. And he actually went to a private company, and you could actually go to, Babies R Us and buy as a shower gift a newborn screening kit and spot it and send it in. But then an interesting thing happened. Parents began to realize that their child with MCAD probably wasn't diagnosed until they became symptomatic in the pre-newborn screening era. And one of the early studies out of Duke said 50% of the children either died or were damaged in their presenting MCAD episode. Other studies haven't found it to be quite that high, but it's still really high. And they began to realize, well, if we could do newborn screening for this, our children wouldn't have had to suffer. So they began to push to get tandem mass spec applied to newborn screening nationally. And that became a should we or shouldn't we argument. So there was one camp that said, we must institute tandem mass spec widespread for newborn screening immediately. We'll figure out the details as we go along, but babies' lives are at stake. We have to do this. And the other was, we don't know what we're doing. We're not sure where the cutoff should be. We can't experiment on babies without parental consent. I mean, this is ridiculous. So there were arguments. And in fact, at one of the Society of Inherited Metabolic Disease meetings many years ago, there was a very passionate argument. And what were some of the things people were worried about? Well, and interestingly, the authors of this paper were some of the biggest advocates for expanding newborn screening to TMS. But even they had their concerns that what's going to happen if you start having a lot of false positive screenings? Are you going to have, if you stress parents enough and a baby's fussy all day, even Mother Teresa could have hit a baby if you pushed her hard enough. Or you could have poor bonding, you could have worry, you could have a lot of problems. So this is where the parent advocacy came in. And then what happened was some states adopted TMS and some didn't. And so a parent would say, why did my child suffer or die when this other person sitting next to me, who lives just 5 miles away, but on the other side of the state line, their child's fine. They're over in the playroom playing right now. And so they pushed the federal government to say, let's nationalize newborn screening. Let everybody have the advantage of this. So this was during the Bush administration. It was during the early 2000s. And so the feds did get involved. So one of the things that happened is the Maternal and Child Health Bureau commissioned the American College of Medical Genetics to outline a process to standardize newborn screening and make recommendations and guidelines for states. Now, you got to remember, newborn screening, it's like marriage. It's run by states. It's not run by the federal government. And so they created updated criteria. You remember earlier I showed you the Wilson and Junger criteria. And so they updated them for the new technology. And it's far too long to put here, but basically the recommendation was you had to consider the disease itself. Was it frequent? Was there a burden of it if you didn't treat it? Did it show up in babies or did it not show up till adulthood? Could the test be cheaply and easily run? And could we manage the treatment and the diagnosis? And were there enough resources? What good does it do to diagnose a child with something and then not have any means to treat it and prevent the damage from happening? So these are helpful criteria, but there was not an appetite to get more government involvement in healthcare at this point. So what happened was with the Bush administration, they created a Health and Human Services Advisory Committee on Heritable Disorders of Newborns and Children, which is a federal committee of experts and stakeholders. And right now I represent the Society of Inherited Metabolic Disorders on it. And this group had a mission to reduce morbidity and mortality in newborns and children who have or are at risk for heritable disorders. And the group was charged with making recommendations for determining which disorders are appropriate to be on the screening panel. And they developed what's called the RUSP, the Recommended Uniform Screening Panel. And I emphasize the word recommended. So this actually was a survey that we filled out. Along the bottom, you'll see the names of metabolic diseases, the first one being MCAD. And physicians, metabolic physicians were asked to score them. How reasonable do you think it is to put this on the newborn screen? And they identified from that 29 primary targets. So remember I said there had been 7? Well, now you are up to 29. And these were disorders that met the criteria. They were common, they were easy to screen for. We knew the basics of these diseases. We knew how to treat them. There were resources available. And so these were now the primary targets. But the thing about TMS, tandem mass spec, is that it identifies other things as well. And in the process of finding out the 29 primary targets, there were 25 more secondary targets that you got information on, whether you wanted it or not. Some of these were disorders that we really didn't know a lot about the natural history. There's a couple of disorders in this list that we still fight about as to whether they're disorders or not, or just biochemical markers. So there are things that you found that you have to deal with. And then the last group was a group that was considered, not yet ready for prime time. So since 2006, when the RUSP came out, they've added a number of disorders as the technology and the screening process has gotten better. And they've repeatedly rejected some disorders that people have really pushed for because they did not feel that they were ethically or medically appropriate at this time. So basically what happened is the states looked at these recommendations and said, we'll do whatever we want. We don't really care what the federal government tells us. So they were starting to add things to newborn screens that were not necessarily widely accepted. I'll be nice here. So in 2008, the President's Council on Bioethics came out with a statement saying states should in fact mandate screening for the diseases that meet the traditional criteria, and it's also okay to expand, but the expansions should be pilot studies and they should be voluntary and informed consent. So Massachusetts actually, when they added TMS to their newborn screen, initially added it as a consented extra add-on. until they were convinced that this indeed was something that we were not experimenting on children anymore. They knew how to run it, and then it became mandated. So let's talk about fatty acid oxidation itself and the newborn screen process for that. So just to remind everybody, short chain fats are fats that have less than 6 carbons. You'll see C3, C4, C5. Medium chain are 6 to 10. Now C7, some of you are on C7 or triheptanoate. It's a 7-carbon fat that we feed patients with long chain fatty acid oxidation disorders. And I won't get into here why that is helpful. Long chain fat, 12 to 18 carbons. And if you see a colon in it, like C14-1, it just tells you how many double bonds were in that. So it's basically carbons and hydrogens, occasionally some double bonds. So don't panic. It's not complicated. Your body releases fatty acids when you're fasting, and it has to hook them onto a molecule called CoA. CoA comes from pantothenic acid. And then you now have what they call an acyl-CoA. Acyl is the name of the bond where the CoA attaches to the fatty acid. But that acyl-CoA can't get into the mitochondria. So outside you have the cytosol or the cytoplasm. I'm taking you all back to high school biology for some of you. And then those 2 yellow bands are the inner and outer mitochondrial membranes. And then inside here is the mitochondria where all the good stuff happens, where all the fat is burned for energy. So if this acyl-CoA can't get in, you can esterify it or join it to carnitine with the enzyme CPT1 or carnitine palmitoyl transferase type 1. And that makes an acylcarnitine, which is a fatty acid esterified to carnitine. And now that can pass into the outer mitochondrial membrane. Then it has to get into the inner mitochondrial membrane where something called carnitine acylcarnitine translocase, or CACT, or sometimes just called translocase. It brings an acylcarnitine inside the mitochondria and it swaps it out for a carnitine molecule. Then that acylcarnitine has to be broken back down by CPT2 it takes the carnitine off it and back into the acyl-CoA, and then the acyl-CoA then undergoes fat burning. So this whole process is just to get the long chain fat into the mitochondria so that you can make energy from it. So the process of beta oxidation, it's named that because it's a 4-step process that oxidizes the beta carbon. Because people think biochemistry is really complicated, but in fact, the names really tell you what they do. So you start with an acyl-CoA. Let's say we started with a 16-carbon long chain fat. The first step is an acyl-CoA, because that's what it's working on. Dehydrogenase. So dehydrogenase, it means it takes away a hydrogen. So this particular step, the enzymes are specific for how long the fat is. So there's one enzyme for short chain fat. Remember, this was the less than 6. One enzyme for medium chain fat, the 6, 8, and 10 carbon fats, and one enzyme for the long chain fats, the 12 to 18 carbons. And why it's named VLCAT instead of LCAT, it's a naming convention issue that is beyond the scope of this talk. Next step, it's a hydratase. It hydrates it. It adds water. And it adds remember water is H2O? Well, this adds the HO from the water. So it's hydroxy. So the 3rd carbon on this 16 carbon fat now has an OH or a hydroxy group on it. So the next enzyme, and so the next set of enzymes are the CHAD enzymes, and that's L-CHAD. Now, also for the long chain enzyme, all of these 3 enzymes are held together in one protein called the trifunctional protein. So some people with LCHAD deficiency are deficient in just the LCHAD enzyme, and some are deficient in the trifunctional protein that holds it all together. Then the last step splits it, and now you have a 14 carbon fat, and this 2 carbon piece becomes a ketone. And that ketone goes out to parts of the body that need energy, particularly your heart. Your heart gets like 80% of its energy from ketones. Your heart loves ketones. So if you have a really serious long chain fat metabolism disorder, one of the things that you can have is a cardiomyopathy. Now, let's look at, remember we talked about tandem mass spec? This is the acylcarnitine profile by tandem mass spectrometry of a normal person. And IS means internal standard. So the sample was spiked with a fixed amount of a known compound that kind of tells you whether your test worked properly or not. And then if you look, you can see the different length carbons have their own characteristic times and signatures at which they come out. So from the short, the C3, to the long, the C18. Well, if you have MCAD and you can't metabolize medium chain fats, those medium chain fats are going to hang around. They're going to esterify with carnitine, and you're going to have a lot of medium chain acylcarnitines. And that, in fact, is what you see in an MCAD profile. You can see here that C6, C8, and C10 are very elevated, but the others are pretty normal. And they can be really elevated. So this is what it can look like. If you look on the bottom, that's a control. The things with the little asterisks on top are internal standards. They're spiked compounds. And you can see that, you know, there's a little bit of some of the chemicals next to the internal standards, but not a lot. But when you look at the top, which is the patient with MCAD, you can see that there's a substantial peak in the C6, the C8, and the C10 column, and the C8 is much higher than the internal standard. And this pattern, this sort of upside down V or TP, is actually helpful because if you feed a baby formula that has high medium chain fat in it, you'll also see more medium chain fat in the acylcarnitine profile, but that actually tends to have more C10 in the MCT. So instead of seeing this upside down V, you'll see a backslash. So it can help you determine what's pathologic disease and what's just from what you're eating. So VLCAD tends to show up mostly as the 14 carbon fats. C14, 14.1, and C14.1 tends to be the biggest and easiest to recognize peak. So that's usually what they're looking for in VLCAD. And then LCHAD, on the bottom is normal. The little D before things is just how their internal standards are. But you can see it's the 14 hydroxy, it's 16 hydroxy, 18 hydroxy. So it's the hydroxy that build up. So you can tell a VLCAD from an LCHAD. So I wanted to show this again to think about this pathway again where carnitine and the fatty acyl-CoA join together through CPT1 to pass into the first mitochondrial membrane. They get booted inside the mitochondria with CACT, or the carnitine acylcarnitine translocase. And then CPT2 splits off the fatty acid, the fatty acid again, and the carnitine. And then you can do beta oxidation. So what would you expect to find in a patient with CPT2 deficiency? And the answer actually is a widespread elevation of long chain acylcarnitine. So you can see the C12s, the 14s, the 16s, the 18s, they're all elevated. So you can see that you could separate this pattern from VLCAD. VLCAD tends to do more the C14s, and the CPT2 tends to get a broader long chain fat profile. And here's a picture of it. And I just want to show you C0, which is over on the left. And again, if there's an asterisk by it, it means it was a standard they spiked. And then the C0 is what the patient did naturally. That's free carnitine. That's not esterified to anything. And then you can see down here, you have long chains. What about CPT1? What would the TMS profile of CPT1 look like? Well, you can only imagine the carnitine is not esterifying the fat. So you're not going to have very many long chain carnitines, acylcarnitines, and you're going to have more carnitine around than you'd expect. And so that's exactly what happens. If you look at the ratio of free carnitine to the sum of the 16 and 18 carnitine, that will be elevated. And so the C0 to C16 plus 18 ratio, it's a direct result of a decreased ability to make acylcarnitines. So now you really can see how we can diagnose most of the fatty acid oxidation disorders using tandem mass spec. Well, what are the pitfalls of newborn screening? I think you all appreciate that this was helpful to know this about your children before they got sick. But it's not a perfect system either. So the RUSP, that Recommended Uniform Screening Panel, and the President's Council on Bioethics have largely been ignored by states. States do whatever they want. And in fact, decisions at the state level are commonly made by legislators and not by doctors and scientists. When I was in New York was adding some things to the screen that the physicians were not really in favor of. The RUSP was not in favor of. And we went to the health department and said, why are you doing this? You really need to think about whether this is appropriate or not. And they said to us, oh, well, we don't control this. It's all done by the legislature. They're the ones who pass the law. So we just do what they tell us. So we actually called in our legislator. He came into the hospital and met with us and said, why are you doing this? And his answer was, oh, well, you don't look at us. We just, the health department tells us what to do and we pass the law. So, there was a perfect system of non-accountability. And so these are the doctors chasing the newborn screening train saying, oh, you left us out. And in some cases, I know Dr. Vockley sits on the Pennsylvania Council, and he actually has been effective in helping to corral the state to some degree and get them on the right track. But that's not the case everywhere. So the other thing, newborn screening is a screening test. It's not a diagnostic test. It does not detect 100% of cases. There may be people in this very conference who had a child missed. You can have false negatives and false positives. And the object of a good screening test is to have as few of those as possible. So you have to think about the sensitivity and the specificity of the test. Sensitivity is if you have the disease, how likely is it to be picked up? And the specificity is if you have an abnormal test, how likely is it that it's really the disorder you were looking for and not something else? So timing is important. So generally the recommended timing for screening is at 24 to 48 hours of life. Now that isn't necessarily true for some other non-metabolic disorders. And so some states do a second screen. When you come in for your 2-week visit with your PCP, you'll get a second screen. Not very many. But you don't want to screen too early. You don't want to use cord blood. You don't want to do a drive-through delivery and test, the baby while, you're cutting the cord. Because you need time for those abnormal metabolites to build up enough to be detectable. But particularly fatty acid oxidation disorders are fasting disorders. Your body's burning fat when you're fasting. And particularly VLCAD, if you have a baby who's feeding that, 2 ounces every 2 hours and isn't ever really fasting, you can actually have normal follow-up newborn screens for VLCAD and still have the disease. And that is something that we learned a little bit the hard way. You have to establish cutoffs between normal and abnormal, and they vary from state to state. So a child in one state might get flagged as having an elevated value, and that same screen done across the river in the next state might get passed as normal. And generally, it's something we just try to learn and figure out. But also some disorders, you know, newborn screening was originally designed for infant disorders presenting in infancy. But some of the disorders present later. And that causes diagnostic uncertainty. For some disorders, we actually can have a little bit of difficulty saying whether your abnormal screen is actually abnormal enough to hurt you. I mean, we used to think of these as either normal or abnormal. And what we've discovered is there's sort of a continuum. And at some point along that continuum, you begin to develop risk. So how much would somebody with a very minimal impairment of their MCAD enzyme have to fast before they got in trouble? Whereas another person can be in trouble the first time they get the stomach flu. So if you think about CPT2, there are some babies with profound deficiency who their organs, as they're a fetus, are sick, getting sick and dying, and cells die, and they're born with cysts in their liver and their pancreas and their brain, where the cells have died from want of energy. And this is incompatible with life. But yet there are other people with CPT2 who show up as teens or in adulthood after they tried to run a marathon with rhabdomyolysis. So these disorders have a continuum, and we have to try to figure out when you're diagnosed where you're going to be in that spectrum. I am aware of 2 children born with VLCAD a couple days apart, one of whom has had a fairly severe course, and the other of whom really hasn't had a lot in the way of symptoms at all. Yeah, but I think probably we'll get muscle symptoms later in life. But we kind of have to be able to predict. And this has led to this phenomenon called patience in waiting. What is it like to be known at birth, to have some disease that's going to affect you sometime later, maybe? How badly, we don't know. When, we don't know. So kind of living your life waiting for the other shoe to drop. And this is an issue. But there's been real blowback on newborn screening. People began to realize that the state now had a repository of the DNA of every baby born in that state. And there's no reason why somebody can't swoop in and do something with it. So this article from Nature, a woman who, quote, raising hell about a newborn blood spot screening, and it could jeopardize the public health programs and derail research and the things that, you know, help your baby be diagnosed. But the problem is she has a point. And we need to think about this point. We need to figure out how we're going to manage this if we want to make sure that newborn screening stays available to everybody. So this actually, I found last night. I added this to my slides last night. China is harvesting the DNA of its people. They're developing a DNA database. And presumably it is for police work. Well, where did that come from? If you remember reading about this, there was a cold case of the Green River Killer who was in the 80s and 90s. And somebody got the idea to go through, they had the DNA of the killer, but they didn't know who to match it to. So they went through one of those companies that you send your DNA to trace your ancestry. And they found people who closely matched and were obviously relatives of the killer, and went in and started interviewing them, taking family histories. until they were able to narrow it down to who this person was. And so you might think, well, that's a really good idea. And yes, but I don't know how many remember the Madrid bombings in 2003. They were terrorist bombings. And there are databases of fingerprints. Like I had to be fingerprinted for my medical licenses in pretty much every state. Now I have to be fingerprinted by the FBI for child abuse clearances. So my fingerprints and of anybody else who's been fingerprinted are sitting in some database. And so they picked up some lawyer in, was it Oregon, because they decided his fingerprints matched the fingerprints left by the Madrid bomber. And Interpol kept telling the FBI that those fingerprints did not match, and the FBI would not back down for quite some time. They did eventually back down, but if you're going to give the government a database of your DNA, you have to make sure you can trust your government and what they're going to do with it and how they're going to handle it. So as a result of some of this activism, some states now require the newborn screening cards to be destroyed or to be returned to the parents. We used to, if a child, let's say, was born and discovered at 6 months to have maybe a fatty acid oxidation defect, and we'd say, well, why weren't they picked up on screen? And we could go get that spot. We could reanalyze it, and we could possibly realize that the samples have been confused and it was some other baby spot, or we could, realize, oh, maybe we need to change our cutoff values because we missed this baby. And if the spots are gone, you can't do that. And some of the labs used to, cut the spots out with the name and, take one of those, you fill out 5 spots. Take a spot and not cut the name off, just have a pile of spots with no name on it, and then use that as the research samples to work up new screens for new tests or new techniques or new ways to do things. And if you don't have the spots, you can't do that. Some advocates have called for requiring parental consent for screening, and that really is problematic. Maryland says that they consent for newborn screening. But if you asked most mothers who delivered in Maryland, not a lot of them remember that. Massachusetts actually consented for the additional screen when they were testing out TMS, but they don't anymore. And, there's a lot going on when you go in to push out a baby. And so with this sort of backlash, parental advocacy is really going to be necessary to make sure that the pendulum doesn't swing too far in the other direction. So what about the future of newborn screening? Well, there are currently federal grants investigating sequencing DNA. So every baby would have their DNA sequenced. You would, maybe they'd implant it in a chip under your skin and you'd put your arm in the reader in your doctor's office and they'd say, oh, well, I can see you're a fast metabolizer of this antibiotic, so for your urinary tract infection, I'm going to give you a higher dose because your body's going to break it down faster. And so, this precision medicine is a great thought. As far as disease, it's still problematic in that what we've discovered is a fair number of patients who trigger an abnormal newborn screen have a novel DNA variant. So for some disorders, there's common DNA variants. We know that variant causes disease, no problem. But for some, it's a variant nobody's seen before. And then we have to try to figure out if that's going to cause disease or not. And so to do genome sequencing for newborn screening instead of metabolite testing, we have a way to go in terms of being able to figure out what different mutations and variants in the DNA mean. I mean, none of us look like each other unless you've got an identical twin listening to this. So we all have variants. So in newborn screen, parent advocacy has made all the difference. Right from the first mother who got Dr. Furling to figure out what was wrong with her children, to the father who developed the first Guthrie test, to the parents of children with intellectual disabilities and JFK with the sister. And in the change to TMS, which is what allowed us to diagnose fatty acid oxidation disorders. So really, you make it happen. So be cognizant of the pitfalls, but keep up the good work. So I am happy to take questions now.
Thank you so much. That was really, really great information, Dr. Arnold. We've had several questions come in, so I'll start with those. If you are an older and not screened as a newborn, are there things that an older person should be tested for if you suspect an FAOD? Oop, are you there?
Say that again.
If you're an adult and did not receive newborn screening and you suspect that you may have an FAOD, what are the tests that are available and that you should be speaking with your doctor about if there's a suspected FAOD?
In general, I don't expect your internist to really know about these tests. So generally, you would want to ask for a referral to your closest metabolic center. And generally, what we would start with would be an acylcarnitine analysis and probably a urine organic acid analysis, which I didn't talk about in this, but it's another way to look for metabolites in the or abnormal metabolites in your urine. So those are probably the things that they might check a CK if you were having muscle symptoms. But generally the tandem mass spec called the acylcarnitine analysis is one of the important ways to start. And generally an internist probably doesn't know what that is. You probably want to go to see somebody at a metabolic center.
Perfect. Is there an optimal time of day after a certain amount of hours of fasting for them to test newborns that are at risk for an FAOD?
Well, not really. Newborns, if you really think what kind of the miracle of a newborn, they have to breathe, suck, and swallow at the same time and coordinate that. And generally, they're not great at that for the first couple of days. And that's probably another reason why mom's milk doesn't really come in for a couple of days, because the babies aren't that efficient getting much of it anyway. So really, the first couple of days is the ideal time to do the newborn screen. But as far as when the baby last ate, they're not really eating a huge amount. That doesn't really matter.
Okay, perfect. If only the C6 and C8 were elevated and only slightly, barely after the cutoff, what does it tell you about the phenotype of this certain mutation?
There are papers out there that have examined the how high the C6 and C8 are and the likelihood that they will be a milder or more severe disease. Generally, we really, really worry about kids who are greater than 15 for the C8. And for the ones, if your cutoff in your state is 0.5 and you come back 0.51, are you going to likely have severe MCAD? And the answer is probably no. And that, even though we've been doing this now for 15 years or more, people are not comfortable saying go home. But on the other hand, in some states, the cutoff is 0.7 and you wouldn't have been picked up. So there's probably some correlation, but it's a little, physicians are nervous taking somebody who has a mild elevation and saying, don't worry about it, because we don't want anybody to be harmed. But the risk is certainly higher in patients whose C8 is higher.
Okay, great. Thank you for that. Where can you find out by state? And you may not know the answer to this question, but we can find the resource if you don't. where can you find the list of tests or diseases that someone was screened for in the newborn screening based on what state they live in?
I think Babies R Us has that.
Okay.
Thinking your state health department should have that information on their website for what they do in their state, but rather than looking up all 50 states, I'm pretty sure that that information is on Babies R Us.
Okay. Wonderful. Can being on D10 during the newborn period affect NBS results, newborn screening results?
Yes and no. If you have a serious fatty acid oxidation defect, you're probably not getting enough D10 in the first 24 to 48 hours of life to suppress it totally and make you be missed on the screen. Mm-hmm. It's possible you could get enough D10 to suppress fasting, but particularly for VLCAD, and that you could, in theory, be missed. But giving D10 to babies, sick babies at birth is kind of standard, and we often still will get an abnormal screen.
Okay, thank you. So we are at the end of our hour. Dr. Arnold, I can't thank you enough for sharing all of this information. I know, the diagnostic journey sometimes is the most difficult one. So to help understand exactly the path of newborn screening and how that all works is really, really helpful for this community to understand. So I thank you for your time and sharing your wisdom with all of us. We truly, truly appreciate it.
Well, thank you.
Absolutely.
It's a pleasure. Okay.
So just a couple reminders before we go. The next session will be with Dr. Vockley. So when we get off the session, you can go back into the auditorium and select the link for the next session. And also just want to remind everybody that the exhibit hall is open. When you're in the lobby, if you just click on the exhibit hall in the upper left-hand corner, it will take you into the actual hall and you'll see the vendor booths. And you just click the booth and you'll be in the booth virtually, and then you'll see up on the top of the screen you can chat with the team members that are in the booth and learn more about each of our vendors and what they have within their booth. So I encourage everyone to do that as well. Thank you again, Dr. Arnold. Thank you everyone for being in this session, and we will see you in the next Zoom session with Dr. Vockley. Thank you, everyone.
Thanks. Bye-bye.